Hello, we're going to talk a little bit about Alzheimer's and dementia. And specifically, I'd like to ask a question that has troubled myself for about 50 years and for many of you in your professional careers as well. And that is, given what we know, why can't we cure these diseases? There are many diseases that we can cure or ameliorate, and Alzheimer's and the dementia in general are not among them. These are some numbers that I've taken off last week, actually, from clinicaltrials.gov. And what you're looking at is the number of interventional trials that have been registered globally for dementia, Alzheimer's, and Parkinson's. And as you see, there have been thousands in each case. And yet, I think all of us are aware that the global consensus is that none of these diseases have been cured. In fact, none of them have really been stopped. In fact, there's argument about whether we can even slow them in any way. This, for example, is a current status with regard to monoclonal antibodies. And as you see, there has been one drug that the FDA has released for commercial use, and that's anakinumab, or Adahem, as shown here on the right. There have been a number of drugs that have failed in the clinical trials. Many people would argue that anakinumab failed as well. There are a number of drugs still in the pipeline, and at least a few of those have achieved expedited status. Now, most of these aim at beta amyloid, a few of them at tau tangles, and there are other targets. But even at the best, if we look at the data, for example, for anakinumab, you get this sort of result. Here you're looking at different dose ranges, the lowest dose being 1, the highest dose being 4, and dose 3, as you see, takes that sort of an odd curve. The point, though, that's intriguing is that in no case have we stopped the disease, let alone reversed it. And in fact, if you look at the vectors of the data over time, you see it parallels the course here shown in yellow, which is the placebo or the no treatment zone. So really what we have is at best a chance of postponing the major symptoms, but by no means even slowing them at that point, because again, the vectors are parallel. This is what we have at our best. And what we obviously would like could be something more like this, where we actually show that we can stop the disease course, that is, make sure it's not progressing downhill in any way, and in fact, improve the clinical status. Well, the problem for years has been this, that, quote, everything works in mice, but nothing works in humans. And that's also true whether you're looking at other rodents, as well as dogs, cats, rhesus monkeys, baboons, and other animal models. Now, about 2 years ago, the Alzheimer's Association and I got together for a conference on animal models in Washington, D.C. And this was the issue. Why is it that, quote, everything works in mice and nothing works in humans? Because a lot of the animal data is tantalizing, but by no means does it carry through to human translational trials. So the question is why? Well, part of the reason, as I pointed out in summarizing the first day's talks, is that we share not all of the genes with, for example, mice. There are about 25% of protein expressing genes that we don't share. And that's to say nothing of regulatory genes. And almost invariably, the mechanisms we investigate, for example, beta amyloid physiology, are not well shared between mice and human beings. So it's not really a surprise that we have a deficit in translational trials taking them to human beings. But I think a bigger problem is this, that we've been digging in the wrong place. And as I say here, if you're digging in the wrong place, then it really doesn't matter how deeply you dig or how big your excavator or how much your NIH budget is, how many people you put into it, how well trained they are, if you're digging in the wrong place. And I think that digging in the wrong place encompasses things like beta amyloid, tau tangles, mitochondrial failure, microglial activation, and so on. The problem is not that these don't occur, they do. But they are biomarkers, they're downstream biomarkers, signs and symptoms, if you will, histological outcomes, if you will, rather than the underlying cause of the dementias. And the result is we're digging in the wrong place. Well, this is a quote from Einstein, and he is correct. We can sometimes know a great deal, but not understand it. A classic case might be this one from 500 years ago, where the Vatican astronomers knew a great deal about the position of the planets, but they had no understanding of the orbits of those planets. And the assumption, of course, was that the Earth was the center of the universe, and that was a flaw. This was pointed out first by Copernicus, and later on by Tycho Brahe, and finally, of course, by Galileo Galilei. But again, it is not that people don't know a great deal. They knew a great deal. They simply didn't understand a great deal. And much the same thing really is going on with regard to Alzheimer's. We know a great deal. There are thousands and thousands of papers, and I see more across my desk every day as you do. The problem is we understand very little. We know about beta amyloid and tau tangles and so on, but we don't understand how these things work, and that's the issue here. So sometimes the problem then is that we're going for downstream things, call them rabbits, This is a quote from a favorite poet of mine in the 8th century in the Tang Dynasty, Li Bai, who said, if you only hunt rabbits, of course, then tigers and dragons will go uncaught. And we have not been catching tigers and dragons, not been curing Alzheimer's or other dementias, because we've been hunting rabbits. And it's about time we dug a little further. So I'd like to talk to you about a unified model of dementias and a more basic fundamental understanding of how these diseases work, including Alzheimer's. If we look at the dementias in general, and most of us are aware of a number of dementia syndromes, for example, Alzheimer's, Parkinson's, vascular dementia, frontotemporal. And these are only a few of dozens and dozens of other syndromes. But one of the things we notice is that while Alzheimer's is a very real clinical syndrome, it sometimes has fuzzy edges. We think of Alzheimer's as a cognitive decline, and yet sometimes it has motor features. So while it may be anamnestic or it may have executive function losses, sometimes we find symptoms that are a bit more like Parkinson's. Likewise with Parkinson's disease, which we think of as a motor problem. For example, in suspension nigra or Meinert's nucleus, we still see patients who do have features that are more consistent with Alzheimer's. They do have Parkinson's, but they share certain symptoms with non-Parkinson's diseases. The same with the frontotemporal, and all of these different syndromes, if we see them in autopsy, we often find vascular problems that suggest there's an underlying vascular dementia. Now, let me stress again, it is not that these are not real clinical syndromes. It's just that there's a certain amount of gray zone or overlap sometimes in the way that patients present. And in fact, the same is true if we expand that a little further. We look at things like Lewy body dementia and medial temporal atrophy and so on. All of these different dementia syndromes have sometimes features that can be a little fuzzy at the borders. And this has brought up the concept of mixed dementias and atypical dementias. And in both cases, we see global conferences on exactly those topics. So over the past 10 years, there's been a growing feeling that maybe there's something that underlies these different diseases and that are expressed in different ways clinically in different patients, given different genetic and epigenetic behavioral backgrounds. And what we're looking at then is this concept of age-related neurodegenerative disease. And the question is there something fundamental that's expressed in different ways in different clinical syndromes, given slightly different patient backgrounds? Well, this is something that has concerned me for about 50 years now. And some 25 years ago this year, I gave the first talk ever on this at, in this case, the National Institutes of Health in Bethesda, Maryland. And the topic I was addressing was the role of cell senescence or cell aging in age-related diseases. And the point that I was making was that if we could truly understand the aging process at its most fundamental genetic, epigenetic, cellular levels, we could do something about age-related diseases. So that begged this question: can we alter aging at the most fundamental level? And as it turns out, the answer is yes. And I'll show you some of the data for that a little later in this talk. But with regard to that animal models conference, it prompted me to put out this paper at the request of the editors of Alzheimer's Dementia. It received 8 glowing editorial reviews, and then it generated more than 600 reprint requests globally in the first 6 weeks, clearly struck a chord. Now, that doesn't mean that the model is correct. It means that people are intrigued by the model, and they recognize that we need some sort of unified model. And when I say unified model, I also mean a systems model, but let's look at what I mean by that. A unified model has an awful lot to explain. We need to explain the heterogeneity within dementias. For example, even if we have 2 patients with classical Alzheimer's, one may get it at age 40, another may get it at age 90. Why the age difference? We have one patient who has more anamnestic quality problems, another patient with more executive function problems, another patient with word choice problems. Why are these differences, these heterogeneities occurring within a specific syndrome like Alzheimer's? And the same is true of the other dementias. What about the heterogeneity between dementias? We can have 2 patients with essentially the same genetic or family or genetic behavioral backgrounds who have very different dementias. One will have Parkinson's, for example, another might have Lewy body or Alzheimer's. Why is this heterogeneity occurring? Can we explain it? Can we explain why one patient gets one dementia and another gets another? Likewise, between species. If we look at almost any animal we want to look at, we find that with age, we see behavioral or cognitive decline in their function. But we also see that there are not only differences between animals in the way that behavioral decline occurs, but there are also histologic or physiologic differences. Again, the question is why? We see hints of an underlying process with regard to aging, but we don't understand why that is. Also, upstream biomarkers and downstream biomarkers, the upstream mechanisms or biomarkers are things like genetic biomarkers, for example, ApoE4 alleles, or history of trauma. We know that patients with head trauma are more likely to get, for example, Parkinson's or Alzheimer's, but we don't know why. We know patients with any number of about 200 different genes can have an increased risk for a number of dementias, but we don't know why. We know that exposure, for example, to a number of toxins can increase your risk, for example, dioxin or paraquat. We know the same is true of a history of microbial disease of any number of kinds. Fungal, prion, bacterial, viral, can increase your risk for a number of dementias, but we don't know why. With regard to the downstream biomarkers, we see the same thing. We see certain of these dementias that have a lot of beta amyloid plaque, others that tend to have alpha-synuclein aggregates, or others that will have obvious tau function problems, that is tau tangles, or will have mitochondrial dysfunction or activated microglia, but we don't know why. Why are these specific changes occurring? So the question is, can we come up with a unified model that's capable of explaining all of these? But we also need a systems model. And by that, I mean a model that explains the dynamics of it, not simply the individual components, but the entire thing. This is an example from engineering. In the upper right, you're looking at a Pearl 15 Rolls-Royce jet engine. In the lower right, you're looking at what powers it, which is a Trent 900 turbofan and a single fan blade. Well, a good engineer, when that fan blade fails, does not simply ask what's wrong with that individual fan blade. They ask what's wrong with the fan blade in the entire dynamic system. That is, how does that fan blade function in the Trent 900, in the Rolls-Royce Pearl 15 jet engine? And in this case, it's an Airbus 380 cockpit, but in the Airbus 380, operating at 35,000 feet, going hundreds of miles an hour at a high RPM and high temperature. In short, it's not simply a problem of the fan blade. It's not as though you laid out each and every part of the airplane on the floor and looked at them. It's how they work together. It's a question of the dynamic system. And that's the same thing that happens with regard to medicine. For example, these are the signs and symptoms, the components, if you will, of the biomarkers of a COVID infection. But it doesn't matter how well you investigate the fevers or the chills, or how exactly you measure the sputum production, or how carefully you look at the anosmia that occurs in these patients, or how carefully you look at the inflammation in the sore throat. It is not a matter of the individual parts. It's a matter of how they function together dynamically. In this case, because of an infection of a COVID virus and the interaction with our human immune system and a number of organs. So knowing the components, the biomarkers, the systems, the symptoms are not the same thing as being able to encompass them all and understand how the system functions. That is, in this case, a viral infection, not simply a list of signs and symptoms. And the same is true of age-related diseases. So, for example, these are a number of macroscopic biomarkers, and we could include a number of the dementias here, of aging. But they do not define aging. They simply tell you about some of the outcomes. Some patients have osteoporosis, some have Alzheimer's, some have vascular pruning, or poor healing, and so on. Fairly common things in many cases, but they are not aging. They are biomarkers or outcomes of aging, but they don't tell you how it works. Even at the microscopic level, the same is true. So whether we're looking at, for example, telomere shortening or methylation changes or declines in DNA repair, or that declining ratio of adenosine triphosphate and reactive oxygen species, that does not tell you, no matter how carefully you measure it, how aging works. It tells you a little bit about the outcome, but it does not explain the system, the dynamic process going on in the aging system. The same is true of the dementias. There are a number of outcome biomarkers we have looked at over the past 110 years, for example, beta amyloid plaque and tau tangles, and more recently others, such as a failure of the blood-brain barrier, lymphatic changes. But none of these, no matter how carefully we look at them in detail, can explain the process itself. How does aging or cell aging work, and how does it result in the dementias? With regard to the genetics, the same problem occurs, as we'll see repeatedly in this talk. It is not a matter of knowing these genes and other genes that increase your risk. The question is, how do they do it? What is the actual dynamic process that takes us from 2 epsilon 4 alleles to increased production of beta amyloid and beta amyloid plaque? And that one specifically we'll look at in this talk. So this is a man that many of you know. This is Dr. Leonard Hayflick. He's the first person who 60 years ago this year described cell aging, and he's a friend. He and I chat occasionally. This is a talk, a quote that he gave me, I used in my most recent paper, and he is correct. What he is saying here is that I think all of us would agree that the single best predictive risk factor of an age-related disease is aging. If you want to know whether somebody is likely to have Alzheimer's, for example, first thing you want to know is how old are they? And that gives you a lead on figuring out whether they might have Alzheimer's. But although most people would agree to that, for example, osteoarthritis, osteoporosis, cardiovascular disease, the greatest risk factor is aging, they then ignore aging and focus in on the histology or the physiology or the biomarkers, for example, hypercholesterolemia or hypertension or beta amyloid. They look at the downstream biomarkers and not at the underlying process, that is the aging process itself. So we need to look a little more deeply, because unless we understand aging, we really can't understand age-related diseases. And from a more practical clinical perspective, we can't cure these diseases. That's where we need to know. And to do that, I'd like to talk a little bit about aging itself. These are a number of species that most of you are aware of. Human beings, for example, tend to live on the average about 3/4 of a century. That is Coco, the gorilla, in the upper left. I actually was her babysitter for a year at Stanford. She spoke sign language. I didn't speak it very well. And that's her little cat, Ball. Well, Coco lived about 40 years, and that's pretty typical for our closest primate here, or second closest primate, the gorilla. If we're looking at domestic animals, for example, in this case, dogs and cats, they tend to live a little less than about 2 decades, some a little more, some a fair amount less, depending on the breed. If we're looking at laboratory rodents, mice and rats, for example, usually looking at 2 or 3 years. And the question is, why the difference in lifespans? Well, many people would say that aging is simply a matter of entropy, but then they're going to have to explain why entropy occurs at different rates in different species. And most people would then wave their hands and say it's genetic, which is partly true. That is, we know, for example, that the mice, as I say, share about 75% of protein expression genes, and presumably the difference in lifespan is accounted for by the other 25% and the regulatory components. Having said that, we have not explained aging. We have simply said it has something to do with genes, which is fair enough, but not an explanation. The same problem occurs when we look within a species, for example, human beings. These are about 30 children with Hutchinson-Gilford progeria. And Bill Sample in the back with his hands up in front of the White House here at the North Portico. We just given him a tour of the White House. These children die at an average age of 12.7 years. They die overwhelmingly of cardiovascular disease, that is strokes and heart attacks. And every child you see here that I gathered here 20 years ago at the White House is now dead of, as I say, strokes and heart attacks. Now, what causes this? Well, as it turns out, we know the gene involved. And I say involved, not the cause, but the gene involved is lamin gene. Having identified that does not tell us how it works. And it certainly does not tell us why these children overwhelmingly die of strokes and heart attacks after about a decade of life, rather than as you and I do multiple decades later. So why does that occur? We don't yet understand that mechanism. The same is true when we look more carefully at the aging process itself, which is not quite universal. Every cell in your body derives from a fertilized ovum, the ovum from your mother, who got it from her mother, and that can be traced back about 4.5 billion years of life on this planet. And during that 4.5 billion years, that cell line did not age itself to death. And yet, your somatic cells, most of them, show age-related changes now within a matter of decades. Why this sudden inflection? Likewise, if we look at the mitochondria in the body, all of which derive from your mother, who got it from her mother, and that line goes back something short of 2 billion years, depending on who's counting. And again, retrospectively, that line of mitochondria showed no evidence of cumulative aging for 2 billion years, and yet in a matter of decades, again, there is a sudden inflection point. Why? Why does aging not occur regularly in the past tense, and yet occurs presently in your body and mind? Well, the answer is clearly not a matter of simple entropy, because entropy has been going on for billions of years. It's a matter of entropy versus maintenance. And what you find is that if you look at the maintenance function of cells like the germ cell line, it maintains itself very well in the face of entropy. That is, every time there's damage, the damage gets repaired. The same is not true of most of our somatic cells. So if I'm looking at the hand of that 90-year-old man in the wheelchair on the left, and I look at the keratinocytes, the fibroblasts, the endothelial cells, the chondrocytes, the osteocytes, what I find is maintenance is just subtly imperfect. And the result is the kind of age-related changes you see in that hand on the left, to say nothing of the vascular system in the brain, and the kidneys, and the joints, and the bones. In fact, you might sort of parallel this as Red Queen theory. And this is the quote from Alice in Wonderland, where the Red Queen said that we must run as fast as we can and just to stay in the same place. That's precisely what's going on in our cells. They're continually replacing and repairing, in the case of DNA molecules, replacing and repairing entropic damage. The failure comes about when that maintenance is not as perfect as it should be. It's not well balanced. So in young cells, what you see is that there's a very rapid molecular turnover. And this is true of almost any molecular group I look at, for example, proteins, enzymes, structural proteins, lipids, glycoproteins, almost anything you look at, even the enamel in your teeth to a small extent, being turned over. And in some cases, it's very fast, in some cases slow, but it is faster in young cells. So for example, if I'm looking at the collagen and the elastin in the skin, or the beta amyloid around my microglia, or some of the molecules, the glyco molecules in my joints, these are being turned over relatively rapidly in young cells, but less so in older cells. Now, the result of this is that when you have damage, signified here by the little red star, it is continually being washed out. So I make a molecule, it may or may not get damaged, I replace the molecule. I make another one, it may or may not get damaged, I replace it. But as the cells get older, the rate of molecular turnover slows in all the molecular pools that we look at. And what you find is there's therefore a gradual accrual of damage, signified here by more of the little red stars. And in the older cells, you find that the result of this is that many of the molecules you and I rely on, for example, aerobic enzymes, for example, myoglobin, for example, beta amyloid, are subtly damaged. And the result of that is cellular dysfunction, and in the end result, age-related disease and death. Now, this can be looked at mathematically. This is taken from my textbook on the topic, my Oxford University Press textbook, which I invite you to read. And what I'm really saying is that in young cells with a rapid turnover per unit time, the accrued damage at equilibrium is very small. Whereas if you look at older cells, where the turnover rate per unit time is very slow, you see the accrued rate of damage over time at equilibrium is fairly substantial. And again, the result is many of the molecules don't work, and the result of that is cell dysfunction and disease. Let's look at a typical organ. In this case, since we're talking about the dementias, we'll look at the brain. And as one of those molecules, we'll look at beta amyloid as a classic. Now, beta amyloid, if we look at, for example, microglial production of beta amyloid, you see that in young cells, it is produced very rapidly, secreted rapidly, rebound, taken back into the cell, and degraded again. This is a continual recycling phenomenon in the beta amyloid molecules. And as the cells get older, what you find is that the turnover rate slows down. So as a result, you see a little bit more in the way of possibility of microaggregates, beta amyloid microaggregates. And you might ask, what happens to genetic differences played out on this stage? Well, it depends on which gene, for example, you have. So if we're looking at an ApoE2 gene, or those alleles, you find that the beta amyloid produced by people with two ApoE2 alleles is not very sticky. It doesn't tend to cross-link and bind. It doesn't denature very much. So even at a moderately high age, for example, 50 or 60, you see very few beta amyloid microaggregates because the molecules simply don't stick together very much, and you have time to recycle them. On the other hand, if you have two ApoE4 alleles, what you find is these are stickier molecules, so they tend to cross-link and bind more, and so you get a higher accrued rate of damage as you get older. So a 40-year-old with two ApoE2 alleles may have no microaggregates, but a 40-year-old with ApoE4 alleles may have many beta amyloid microaggregates. And in fact, you can look at the risk over here on the left. With one beta epsilon 4 allele, you have 2 times the risk. With 2 of them, you have 3 times the risk, and you tend to see the disease earlier. So the genetic predilections matter, but they are played out on the stage here of cellular aging and changes in molecular turnover. And in any case, as we get older, that turnover becomes so slow that most of us will end up with beta amyloid plaques. And the question is, what's the outcome of that? Well, if they're severe enough, obviously, the outcome is synaptic loss, cell dysfunction, a loss of neurons and glial cells, and clinically, we see the dementias. Now, I've only used one example, that of beta amyloid, but the same is true when we look at other molecules, for example, tau proteins or some of the mitochondrial proteins we'll look at in a minute, inflammatory changes, and so on. So there are multiple things going on. And if we were, for example, to use something like anakinumab and simply go after beta amyloid, we are only getting one of dozens of molecular changes that are resulting in age-related neurodegenerative disease. Speaking of the mitochondria, we see the same sort of problem occurring. For example, 99% of your aerobic enzymes derive from the nucleus, where we see slowing of the expression and the turnover rate of these aerobic enzymes. So they have longer time in the mitochondria to be damaged. And in fact, the result is therefore inefficient production of energy. In fact, your ATP and reactive oxygen species go down, a ratio goes down with time. So you're creating more reactive oxygen species. Furthermore, the lipid membranes around your mitochondria are also being recycled, but more slowly. So the porosity goes up, the membrane integrity goes down, and these increased number of reactive oxygen species are more prone to leak out of the mitochondria, where they're usually scavenged by molecules like superoxide dismutase or catalase, which themselves are going down in the recycling rates. So they tend to be more dysfunctional, and the result is poor scavenging. And the result of that is more damage to other molecular species, which are themselves being recycled more slowly. So for four independent reasons, in this case, you're looking at increased damage to the cell, simply having to do with mitochondria. The same is true when we look at, for example, DNA repair. There are four families of DNA repair enzymes that could loosely be construed as detection, excision, replacement, and ligation. And all four of these independently are slower in their rate of recycling and turnover. So you don't detect, you don't excise, you don't replace, you don't ligate as efficiently as young cells do. And so they go up exponentially. These are four independent factors. They cause an exponential increase in the rate of mutation and therefore age-related cancer, independent, by the way, of years. It's the species lifespan. So the exponential increase in mutation and cancer goes up with mice in 2 years, and you and I say in 80 years, but it's the same curve. So overall then, what we're looking at is cell aging and cell senescence as a central process that mediates between the upstream risk factors and the downstream biomarkers. Now, these upstream risk factors are things that can increase your rate of, for example, cell loss, and therefore cell division, therefore telomere shortening, which itself changes the epigenetic pattern, which causes molecular turnover to slow, resulting in cell dysfunction. And we can go into detail on this if you'd like to, but there are a number of articles on my textbook. You can look at it in more detail. Let me give you an example. If we're looking, for example, at head trauma, what does that do to cell division? Obviously, it causes some cell loss. The same is true, for example, if we're looking at the vascular endothelial cells. Hypertension, hyperglycemia increase your risk of damage to vascular endothelial cells, resulting in increased rates of cell senescence. And a number of these things do. As I've said, toxins do. The problem itself with genetics risk factors play out in this stage. Downstream risk factors or downstream biomarkers, the beta amyloid plaque, tau tangles, poor reactive oxygen species, scavenging, all of these occur in many cellular systems, not simply the brain. But the question that I think we need to ask ourselves practically is, where can we intervene optimally, both clinically and financially? Well, for hundreds of years, we've been trying to intervene upstream. We know, for example, that if we lower your risk of head trauma, we lower your risk, for example, of Alzheimer's and Parkinson's. If we can get good control of your hypertension and make sure you're euglycemic, we can lower your risk of vascular disease, in this case, vascular dementias. So there are a number of things we have tried over the years to do to lower the risk upstream. And downstream, more recently, we tried things like use of monoclonal antibodies for those first two downstream biomarkers. The problem is that none of these, as you've seen with regard to anakinumab, are very effective. The question is, can we do better? Well, the obvious target then is a central set of mechanisms. So rather than attack simply beta amyloid or simply tau tangles or any one of the other dozens of other biomarkers, or simply trauma or simply infection or toxin exposure, can we in fact do better by looking at the central mechanism, the most efficient target, which would be telomere shortening and gene expression changes, that is epigenetic shifts? And the answer, as it turns out, is yes. And I say that not for theoretical reasons, which I went into in the paper, but for data reasons. This is a classic paper from Science Magazine 23 years ago, where Andrea Bodnar and her group at Geron Corporation in California showed that you can actually reset cell aging in human cells in the laboratory. Specifically, you can reset the epigenetic pattern using specifically telomerase. So you can actually take old human skin cells and turn them into young human skin cells in the laboratory. Now, the same is true not just of individual cells, but of tissues. This is a case from Walter Funk and his group in experimental cell research now 21 years ago. And what they did was the same sort of thing. In this case, they used human skin cells to grow human skin. And they showed that if you take young human skin, you can grow from young human skin cells, you can grow young human skin. From old human skin cells, you can grow old human skin. But if you take the old human skin and telomerize it, reset the pattern of gene expression, you can grow young human skin. So you can literally take old human skin and grow young human skin by resetting the pattern of gene expression using telomerase. Furthermore, this works for osteocytes, in case of bone, and it works for vascular endothelial cells. So literally, again, you could take old coronary artery tissue and grow young coronary artery tissue solely on the basis of resetting gene expression by the use of telomerase. So we also know you can do this in organisms. This was originally done by Rhonda Pino's group at Harvard, in 2011, but this is the case where it was done using a technique that we can use in human beings. And you find that you can actually increase the lifespan, not only increase the physiology, that is the bone mineral density, subcutaneous fat, and immune response, but actually increase the behavior back to youthful levels. So what we're going to do is target the causes, that is the tigers and the dragons rather than rabbits. We're going to take this to human trials, reset gene expression. Our primary initial target will be the brain, dementias, followed by vascular disease. But this is a platform disease therapy. It works for cells in the brain, the blood vessels, the joints, the bones, the kidneys, as well as the immune system and skin. Our major concerns besides safety and efficacy are credibility. So we're going to make sure we do this very rigorously. We have been very careful in who we chose for the clinical advisory board and scientific advisory board to make sure that they are skeptical and careful about what we do. We're going to use a single dose of an AAV hybrid and a human telomerase gene in a custom cassette and take this to human trials. So this brings us back to the question I asked originally, which is, can we alter aging at its most fundamental level? And the answer is, we can. It's certainly true in cells. It's true in human tissues. And I think it's true in human patients as well. So we will find out. Thank you for listening as we talked about a unified model of age-related dementias, and for that matter, age-related diseases. For those of you who'd like to know more or talk to me, please feel free to get in touch with me. Thank you for joining me.